So benign lesion in the cecum, elderly patient on apixaban. So we're going to remove this by EMR as we discussed, and it's actually at the 6 o'clock position naturally, so he didn't have to turn the patient. The fluids on the other side, as you can see. And what we did is there is a small fold in front of the lesion, which we injected behind first. The purpose of Tomáš was to get the lesion towards him, but what happened is actually the lesion went away from him, went towards the caecal side rather than the anal side of the colon.
The elderly patient, right colon and on antico.
John, I assume this one you would close as well with the information you've got, because I heard your discussion before.
Open, please.
So he's an elderly patient. He's on apixaban and it's in the cecum.
Yeah, it ticks all the boxes, Lob. I would say that, the risk is increased because of those factors, but actually there's been no intraprocedural bleeding. It's a really clean base. But yeah, I think when you're considering whether to clip or not, you've got to understand the balances here. So the balances is it increases the time of the procedure, it increases the cost of the procedure, and it increases the technical difficulty of the procedure because you've got to do something else. And that has to be balanced by the cost of a hospital admission due to a post-polypectomy bleed. And I think if you have a hospital presentation or a hospital admission, the costs are blown out the water. So then it comes down to numbers needed to treat to enable that to be cost effective. So from a purely financial perspective, that's what you have to have in your head. But we function at a patient level, and we should really probably be thinking about what's best for our patients. But when you're thinking about these things, as I say, there are lots of different factors and ways to think about it.
But I would re-excise this, and it's maybe interesting to demonstrate to Tomáš how to do that. Yeah.
Yep, you can. And so you see those small vessels, right? These are a bit of a telltale, I find, of the lamina propria.
Incomplete mucosal excision, but indeed of the lamina propria itself. Yeah.
You can see it's like little vessels, like gently oozing. Usually, that's very typical.
Usually, prior to re-excision, we need to inject.
You need to inject. The other thing is that why we can say this will probably be okay. It's caused by his sheet. I think on the recap we will see that it wasn't.
Look, I think it's better that you do the re-excision because one, it's a way outside the box technique, and two, it's something that can be nicely demonstrated now, and then Tomáš can do the snare tip soft coagulation. If a trainee has failed an excision, you have to be very, very have a lot of time, have a lot of faith that the re-excision is going to be okay in that situation. So I think you should demonstrate this.
Okay, so we're talking about this. I'm going to lift it nicely. Yeah.
To talk about the differences in technique, Lob, I'll just talk while you're doing it, if it's okay. The differences in technique for the re-excision of IME, join in, please, John, if you want to, is that usually you can inject directly into the defect. We are usually actually planning to resect part of the defect because we have got too superficial a excision. So usually you have to involve defect in your excision, something we're often not doing, right? And you really need excellent technique. Like you must push down hard with the snare. You must maximize your positionality. And sometimes you need to do pre-excision. That's a cold snare. I don't know whether that's what you want.
It is a cold snare. You want it to be a hot snare excision. Sorry.
And the last part about IME is that, I mean, you can do it with that snare. It will work, look. It may even be better because it's very thin wired, but yes, re-excision of IME, you cannot do it with cold snare because cold snare is very often limited to the lamina propria anyway. So getting a very solid submucosal specimen, that's not happening with a cold snare technique. I'm not saying it wouldn't have worked with that snare. Maybe it would have. That is a hybrid snare, so potentially it would have worked.
Mm-hmm.
Nice. Look at this.
So you really want the I'll say lesion.
The defect has to come with it. Yeah.
Yeah, and you
good.
really
I
want
think
it
this is excellent.
to bunch up in your snare. So I'm pushing down not too hard, but I'm really advancing my scope in. So so it's yeah, very easy. So yeah, go ahead, Fanny. I'll try to keep the view for you. Yeah.
Very nice.
Yeah. So she's already changed the processor. Very nice. Thank you. So, and what I showed Tamaj is I really don't want to close. I just want to let the coag do the work. So we have a nicer, wait, what they have now? Nicer, what's it called? Defect, nicer.
Easy to interpret, nicer, crisper edges. But what is the problem in this image? Because this image, and now I would like to be able to copy this and go back, but I'm going to remember 1938, and I'm going to go back to the other one. Where was it? Here, maybe just here. Okay, this. What is the difference between this and 1938?
It is more embedded.
Yes, right. It's more embedded. And what else? There's a clear difference.
It's much more. So
There's much more in the snare.
yeah, lots of normal.
Lots of normal. There's much more tissue in the snare.
Yeah, and the snare is more out at that time.
In the other one or this one?
It is less out, and that one is more out.
Okay, so got more effect of the tip on this. Okay, yeah, maybe that's true. I mean, I still think it's not terrible, the other one. That's not the issue. So the issue is that when you remember this and we go to 1938 then and have a look at what 1938 looks like, hard to get to, oh, yeah, not bad, 36. Then you have not got enough tissue in there. And it's entirely predictable that what's going to happen when you close this, and I was saying it to these guys in the room, as you did it, is the slip. And what should happen? So the V does not stay in this position, but as you close, it slips onto the polyp. So all your front is lost, and it's not that you lose it completely, you just cold snare it, right?
Yeah.
And then what happens is, okay, there's always this moment in training, and then, you know, what should I do? Should I open? Should I close? It's cutting. Oh, should I stand on the pedal? What should I do? The assistant's probably handing it to you.
Exactly.
This happens. I think my problem with it is that as a trainee, receiving the news of 36% is not encouraging. And I wonder whether we can apply that lesson that we learned, Maria, in the tip control thing to this, as in some sort of better normalization than because the problem is that it's on the same scale as the whole score. So it's like I give him a score of 76 or 71, and then I say, oh, actually, by the way, really, in real life. I mean, nobody wants to hear that. So maybe we have some communication work. John, what's your view?
Yeah, it's an interesting discussion, David. I think the point you're making, and it's very, very valid, that your skills are applied to the polyp in front of you. So the technical difficulty associated with this polyp, there were one or two, but on a scale of things, it's not massive. So, it's not inside a TI, it's not an LSTNG, it's not got fibrosis, it's not this, it's not that. The access is really easy. So, if I was being completely objective, as you improve, this should be a relatively straightforward thing for you to sort out. So you'd be expecting to go towards perfection, because if you're not really good at this lesion, then the more technically challenging lesions are going to test you beyond your capabilities, I think. So, on the scale of polyp technical challenges, this is not the greatest one. So the fraction there is a difficult thing for them to possibly take on board, as you rightly say. They've all got good skills, but they need to know where to target their improvement. And I think this just puts things in context. I think in medicine, particularly in this day and age where everyone's been super nice to each other, honesty can be very difficult to accept. But the truth is, if you're going to be effective as a trainer and you're going to induce a change which has an impact on that individual's technical abilities and career progression, you need to be able to say, this is in context with everything else. So you did fine on this polyp, but in context, this is a kind of low-hanging fruit, is the way I would phrase it.
You agree with John? We didn't ask your opinion. Do you agree with 71% as a kind of overall, or 70% as an overall performance score for that polyp?
Yeah, I'll put my hand up for that. I think that's fair assessment for this polyp. Yeah, but I would put it in. As I say, it needs to be in context.
You have to see it as a bad thing, 36, because as Tamas said at the beginning, he's starting his polypectomy journey, let's say, his EMR journey. If we were to say you are doing 70% in the overall scheme of things, you're doing 70%, I wouldn't believe it, and that wouldn't be a correct thing. So I think it's more as a positive thing, like you did very well in this one, and you will see, the more you progress, you will see that weighted score going up more and more, because you'll get better and better.